it's really about what's in our notes and why. And if we wanted to get this done, how and where would we do it? And we're just looking at what's available to you right now, what's getting in the way of the charting, because often you come out of the room, you might have a spot where you can finish that note, but instead you check the work list or you answer a phone call or you get interrupted. So it's like, what is getting in the way? And then, of course, if for instance, templates help you, if dictation helps you, if some of the newer AI scribes help you, anything that makes this simpler, easier, and done, we're all for it.
The whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Cherry Live. I'm Dr. Jordan Valrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about Canadian healthcare. Join us as we speak to innovators, industry leaders, and people working to drive the health system forward. Dr. Sarah Smith is the charting coach for physicians and a practicing rural family physician right here in Alberta. She's the founder of Charting Champions program, helping more than 150 doctors in the specific area of getting home with their charting for the day already done. Dr. Smith has a passion for reducing burnout and the overwhelm resulting from the administrative burden of clinical medicine, which is a huge topic of debate amongst the medical oversight bodies right now. Sarah's married to her husband of 21 years and has 2 sons and lives on a small farm. Evenings and weekends are spent pursuing enjoyments like farming, exploring, and reading. Dr. Smith, thank you so much for joining us on the podcast today.
Thanks so much for having me here.
Why don't we start with, what is Charting Champions? Where did this come from? How did you get the inspiration to actually dive into it?
Perfect. Yeah. So Charting Champions is a lifetime access program for physicians where we really want to help physicians with how do we redesign the clinical day to help them contain the clinical day to the clinical hours and get home to have a life outside of medicine. So that looks like foundational modules, community of their peers, and lots of opportunity to come in for that specific help with their expert peers who are trained as executive coaches, or with our guest coaches every month that we bring in to have a different perspective. I'm not the expert in every topic about the clinical day. So we bring in people who do leadership training, access improvement, ADD, and executive functioning management. Anything about the clinical day that physicians are struggling with, that's what we do at Charting Champions. So how did it come about? It came about because I personally had an issue with charting paperwork, getting home on time. And I was 15 years in this role as a family doctor and still unable to tell husband when I'd be home. I still wouldn't be done at the end of the day. I'd have lots and lots of evening, weekend work that was using up my time. And I did not know there was a solution. So the only help I got from my mentors and colleagues was you just do it when you can, you come in on weekends. And that wasn't the answer I wanted. And it wasn't until I kind of discovered coaching and what coaching could do in regards to helping me be the owner of my day, to find a different experience of clinical medicine in my day, and to help me really dive into the redesign of the day so I could get the work done, that I could make a difference for myself. And then when you get bucket loads of time, suddenly you just want to share this with the world. So I started coaching one-on-one family doctors, and then specialists would come to me, and then other allied health professionals would come to me asking for help in that exact same area. So after I got kind of fully loaded up with one-to-one clients, we then said, okay, we now understand the problem. We understand the framework of how to get people out the other side feeling better. That's when Charting Champions was put together and launched 3 years ago.
So it truly evolved out of a problem that you yourself were experiencing and had to come up with solutions for.
Exactly. So I thought it was the impossible, unsolvable problem.
And how much time in your day did you save yourself? Because I'm sure this was something that evolved over years, and you've honed your craft of having your workflow and your processes dialed in. Like, how many charting hours or administrative hours and, patient care interaction time were you spending in an average week?
That's a great question. So after the last patient left, it would be 2 hours before I would get the text from husband reminding me it's time to come home. That it was dinner time. So I would pack up knowing that I wasn't done. So that was 2 hours. Then when the kids were in bed, I'd be back on the computer for around about 2 to 4 hours a weekday. And then I had this wonderful experience where patients hand you a form at the end of the visit and they say, oh, you can get that done when you have time. And that those,
By the way, I have this EI
hey,
form I'd love for you to fill out, when you have a minute. No big
when you
deal.
have a minute. So what I would do, I would take those, 3, 5, 8 forms home on a Friday, expecting to try and get to it on the weekend. And then I would spend all weekend telling family I couldn't because I had paperwork, and then go back to work Monday with them still not done. And so it would actually use up the entire weekend of mental load, but not doing paperwork. Or I would get up early in the morning, or I would spend, all of Sunday doing paperwork. So this was I'm going to say I was one of those 18 to 20 hour physicians, pajama time. It was very overwhelming. Mm-hmm.
Well, and so recently there have been some studies across the country here showing that there's about 80 million hours every year of physician time spent just doing administrative work, paper tasks, a big chunk of that being what's viewed by the doctors in the surveys as unnecessary work,
Mm-hmm.
just frivolous stuff that either doesn't need to be done, could be delegated to a team member, or just otherwise shouldn't be plugging them up from actually treating patients.
Yes.
Like, does that sound realistic to you? Does that sound like a huge number, or does that sound like an
Yeah.
undershoot, even in your opinion?
Oh, no, I think the administrative burden, if anything, since I started in my career, is bigger. Certainly, COVID created a whole lot of work lists and inboxes we never had previously. We currently have the amazing experience in Alberta, for the Alberta physicians listening, of Connect Care. And so if you happen to have Connect Care access, you now have this siloed work list of things to go and mark completed, which doesn't interact with your EMR. So now you have double workload of things. So all of this is creating increased non-physician work, especially when you've already seen something. Now we're duplicating it. Now we might be triplicating it when it's in this siloed system. So yes, if we don't take some major changes, we're going to run out of minutes available. So they say with adult primary medicine care, if you were doing good care for your panel, it would take 27 hours a day. Well, there isn't 27 hours in a day. That was one of the studies that came out last year. And I'm like, yes, I hear a lot of physicians say for every hour in front of a patient, I have an hour of paperwork or not patient time. And so that becomes part of the work of the day is, okay, how do we empty these work lists in the most effective way for where you are right now with the staff you have, with the EMI you're using? How do we get out of this as fast as possible? Yeah.
Well, and it sounds like there's a lot going on behind the scenes here, right? So it says charting right in the name of the venture, obviously, but clearly there's more going on in terms of leadership skills and practice management. Let's chat a little bit more about the charting side of things. Like, what are some strategies that a physician or even another healthcare practitioner could implement so that this isn't dragging into their evenings, needing to be done on the weekends?
Yeah.
Are there some high level, just general tips you'd have to offer there?
Yeah. So the framework that we use for physicians are kind of 4 steps. First step is to get our charting done after every patient. And that's kind of the foundational step, because even though it feels impossible, if we're carrying those patient encounters with us through the day, we're adding to the working memory of the day and we're crowding our brain, right? So
Get it
what will
out there
often
while it's fresh.
yeah, exactly. So while it's fresh and it's current, like it's fresh in your mind, so you're going to collect accurate information. And as we complete that encounter, there's no homework from that encounter. Yay. So we want to ensure that that encounter is done. All of the aspects of that encounter complete before we move to the next patient. And that takes a minute for a physician to kind of get their head around. And then the implementation of that could take a while. There could be a significant difference between what you do now and what you might end up doing if you decide that this would be something you'd like to implement. Step 2 is the clinical encounter. Like, physicians have a set number of minutes with a patient if they're in that appointment book style, or they have a waiting room full of patients if they're in the emergency department. Like, we don't have all day with a patient. So we have...
It doesn't end, though. There's always more. There's more work to be done. I mean, with the physician shortage, right, and
Yeah.
that like sense
Yeah.
of duty, it's just, it doesn't stop unless you have some sort of barrier or boundaries you start setting up.
Yeah. So the in clinical encounter, we hear physicians saying, my patients are demanding, entitled, they bring a list in, they have multiple issues in the room. But the boss of the encounter is the decision maker in the room. So that's your physician or a clinician, is the expert decision maker in the room. And understanding that you have the ability, with the language you use, with the way you're setting up your appointments, to be able to start to contain what you will say yes to today. And when you say yes to something, you say yes to all of the aspects of that. So if you say yes to 30-second shoulder added on problem in this encounter, you still have to assess it, document it, and arrange anything about it that you needed to arrange. So the patient never understands how long it's going to take to do a puzzle. Like, hey, just a quick question about my headaches. I'm like, that's not a quick question. We know how long it takes to do a good headache workup. That's your job. And all the minutes and seconds count. So what are they leaving the room for? Are they being interrupted doing that high level work? What do they spend their time on in the room? That step 2, can be there's a big amount of things inside a clinical encounter and how you do your work of the day. So that's kind of step 2, is trying to help them lead their encounters in a way that feels good for them and helps them keep that relationship with their patient and doing their highest level work. Step 3
So
is
saying no to some things, I guess, right, is key there.
it could
Like,
be saying no.
phrasing it. Yeah,
Yeah.
like, this is a, big problem, or maybe not a problem, but this is a serious issue that, we really should give it the time it deserves.
Yeah.
Make sure that we fully unpack this,
Yeah.
right? Because it is in the interest of the patient and the benefit to them, right? Like, if you're going to, kind of half do a lazy job with it in 30 seconds, I mean, you're not doing a service to them or yourself.
That's right, exactly. And it is about that quality of patient care. So that's really important that we have the language we're going to use with our patients for how do we defer this to next time, or what are we saying yes to and why in the room, and how do we start to negotiate that. Even how we start and end an encounter can add minutes to the encounter, right? So
Well,
it's
and then I imagine
noticing
that
all of it.
agenda setting up front is key.
It can be, but for some physicians, that really gets them bogged down. So it's not just agenda setting. Sometimes we have to just put that down because it's too hard. It creates more problems. But we do need to give them an approach for how they're going to address this encounter. And it's not one problem per visit, because a lot of physicians won't do that because they know that access is a problem and getting them back is a problem, and some things are fast. So they do want to be the owner of that appointment, the boss, the one who's deciding what will and won't be done. Yeah.
Well,
So then,
it's tough, right? Because patients have booked a day off work or a half day off work. They're taking time out of their busy schedules to come see you. And so if you're just kind of superficially cutting it short based on a general rule there, you're not really, is that fair to them?
yeah. So it's that knowing which patients are needing that time now and which ones are we going to bring back quicker because they aren't having to have a whole half day off or whatever. So yeah, all of that's part of the clinical encounter. Absolutely. Yes.
And then, so how would you phrase that to a patient? Let's say you're seeing somebody, they look like there's a few different things to be addressed. Like, what would that first encounter couple sentences out of your mouth even be?
Yeah, so one is guarding what you're saying as you walk in the room. So the how are you today is about a 3-minute cost, versus what are we doing today gets us kind of closer to the mark of what's of importance to you today. And it can be that question of what is important about the things you're bringing in today and what are we going to put into next time. Or they might say, hey, just one more quick question. I'd like to, talk to you about my headaches. we can do that general inquiry around triaging the problem just so we understand, is this I'm going to stop and do this right now? Or am I, okay, that sounds important. Let's get you back in so we can dive into that. So we'll book that in for next time. So it is that deferring but it's using the language that feels comfortable for you, and you need to practice it because it doesn't come out naturally the first time you use it.
Now, how do you build that patient rapport? That that human aspect of the interaction. Because I'm a sucker for this one. Like, hey, how's it going? And
Yeah.
then you get a Grandpa Simpson story, which just goes on and on and on. And then, just like you're saying, yeah, next thing you know, 3, 4, 8 minutes have elapsed, and like they'll
Yes.
talk about something very personal, which
Yes.
is you don't want to cut that off if there's been
Yes.
health problems in the family or something else related. Like, how do you capture that kind of like personal connection versus the utilitarian aspect of like, we have a limited amount of time and a job to do here?
Yeah. So it's the when can we do this? Do we have to do it every single time with our patients? So we can, what are we up to today? We can get into the meat of the problem, and then I might be doing a referral letter. And the way my brain works, I'm quite happy if they're nattering on while I'm doing something in the room. So I'll be doing that referral letter that they want done, and I'm like, how's the grandkids? And they can chatter and natter as I'm doing my thing. We
That's
have a
genius.
great
Okay.
interaction. I love my patients. I love having that understanding of who they are and what they're up to in their world. I'm in a small town. They know what I'm up to, and they ask about how the farm is, how the kids are, how the everything is. But we need to remember it takes up a lot of time. So we want to do that when we have time.
Yeah, while you're filling out a prescription or something else, and then you've got that other half of your brain actually on social mode, listening
Yeah.
and
And
nodding
not,
and
yeah.
smiling and asking questions.
And not every physician can do it that way. And that's okay. But for my brain, it's fine to do that. Yeah.
And so, okay, so we've talked a little bit about like how to manage the encounter in terms of the charting itself. Like, what kind of strategies do you employ to actually get the charting done as you go? Like, is it
Yeah.
as simple as extending your appointment visits, or is it cutting the appointment with the patient short and giving yourself time to chart? Are you using, scribe tools as you're going, like, or a
Yeah.
combination of everything? Like, how do you get the charting done so it's
Yeah.
not this monkey on your back all day?
So most physicians have a set appointment schedule set up for the next 8 weeks. So we're going to go with exactly what you have right now. We're not going to take out patients. We're not going to extend appointments. None of that's actually going to be helpful in the long term. But the doing of new things is hard, and it will be slowed up by the trying of new things. So just know that it's supposed to be messy in the middle as you're trying to figure it out. Step 2 is, what are you already doing? Because that's familiar to you. So how do we kind of enhance what you're already doing? And I think that's important, that you're not always trying to just do the newer thing because it could work for you. It's really about what's in our notes and why. And if we wanted to get this done, how and where would we do it? And we're just looking at what's available to you right now, what's getting in the way of the charting, because often you come out of the room, you might have a spot where you can finish that note, but instead you check the work list, or you answer a phone call, or you get interrupted. So it's like, what is getting in the way? And then, of course, if for instance, templates help you, if dictation helps you, if some of the newer AI scribes help you, anything that makes this simpler, easier, and done, we're all for it. But we don't have to go looking for fancy to start with. We're just saying, if you wanted to not do this later, how and where could you start? And just
Back
making
to
it as
basics.
simple as possible. And
Yeah.
all of the physicians inside the program will be doing it in their own way. I tend
What
to
are
not
you
use
personally
templates.
using in terms of fancy
Yeah,
tools? What do you got on the go? Drop some
I don't
names
use
for us here.
templates particularly. I think I have 3 different types of chart note that I can use. I use one template only, and that's because the college requires a lot of must-dos for opiate prescribing. So if I'm doing an opiate prescription encounter, I'll use my template for that so I can remember to tick off all the must-dos. But otherwise, I'm just using a general note myself. I'm typing mostly in the room, and then immediately after, I do have pre-filled in forms for lab requisitions, because that makes life easier and saves some seconds
Yep.
there. So That's me personally. That's how I've attacked it from my point
No
of
templates. You're just out there
view.
doing it. How many words a minute are you typing?
I can type at talking speed. So I don't know my actual type, but I'm pretty okay with what. And it's not, I'm not recording word for word. This is so what I heard you say was concise summary, write it down. So as I talk it out to the patient, I write it.
Pertinent positives, pertinent negatives.
Pertinent positives, pertinent negatives. What happened? What do I need for billing and insurance purposes? Why do I think this is my working diagnosis? What was my supporting to and fro data? And then what's the plan?
And what's your typical patient appointment visit duration?
Mine at the moment are 15, and I have over the course of the 18 months it took me to figure it out, and through COVID and through the changes that the Alberta government were planning to implement, and with virtual kind of appointment styles available, I have pivoted and changed up everything, and I'm not afraid to do so. So right now I'm on 15-minute appointments. I've done 10 minutes. I've not done any less than, so I haven't gone less than for an hour ever, except for the occasional like longer visit that I might have intentionally planned for one of those undifferentiated patients that you really just want to dive into that meaty detective work.
Here in Alberta, 15 minutes, I would say, is probably the most common thing we see. Like, it seems to be kind of a nice balance between time and efficiency, and there's the billing code time modifier lines up with it, so the actual like business logic behind the scenes. So I think the vast majority of doctors are probably on that 15-minute schedule. I locumed once for a doctor at his whole patient panel was trained for years or maybe even decades for these 10-minute appointments. And man, did that ever give me anxiety. But we got it done, but it was a lot.
Yeah. We've had physicians, though, join the program who want to keep their 40 a day, and they do, and they still get their charting done as they go. So it's possible, whatever of the environments you work in. The key is that if you want it sustainable, we need to be doing the work of the day within the day. So it's figuring out how and where we're going to get that done. Yeah.
Well, while it's fresh, before it starts, because the details get fuzzier the longer the duration elapses between when you see the encounter, you start, was that a positive sign on the abdominal exam, or was it, kind of iffy? And so, medically speaking, it's probably going to be more accurate too, as well as more effective.
Yeah, correct. For informational continuity, it's perfect, because then if you've got like the US physicians will have an MA coming behind them to carry out the orders. If those orders aren't in, they don't know how to do their job. And the patient's waiting on the orders, and you're in the next room, and then you're getting buzzed. What were the orders? And the whole thing becomes very messy. So there's a lot of liberation for the team as well as the physician or the clinician as we start to do this work in real time.
Tell me a little bit more about your team. How do you actually set up the workflow with the other people in your practice?
Yeah. So not every physician or clinician is hire and fire in their clinic. And so we are looking at who is available, what are they mandated or able to do for you. And that's part of that next step is the work lists and the other work of the day. So everything else, and part of the interruptions. So that's kind of the managing the rest of the clinical day. So who's interrupting you? What are they asking you? How do we start to batch some of those interruptions so that we're not having that constant interruption? And some of the physicians I've worked with knock every single patient encounter. Can you imagine? So that high level work, you're doing your expert level work, and suddenly there's a knock, knock, knock on the door. And they're like, so-and-so's late. Will you still see them? And you're just sucked out of that patient encounter, and you're thinking, what do I got to do this afternoon? Do I have time to stay if this person's late? And what are they coming for anyway? And then you got to go back and reorientate yourself to the patient in the room. It is so adding to our decision fatigue and so interrupting that executive level work is so important to protect your time, and no one else will do that. That is your job. All of the things in your inbox eventually get out of your inbox, but how are we getting it out, and how can we get it out as fast as possible? So for our clinic, with the EMR we're using, which most EMRs are kind of, not set up for us to have great workflows, it was working with the team to say, okay, how do I bring a patient back in 3 years for a pap smear without me having to remember that they need one? Like the next time I want to know that they're ready for one, they're in my room because it's time.
Yeah.
And it takes all of the work off the physician. That was the very first puzzle I had to deal with when I got here from Australia, because that recall system has been established over the last 20 years because it's our responsibility, says the college, to remind the patient that they're due for something. So we had to figure it out. Here, there wasn't that same emphasis. So now I'm like, because when I first arrived here in Canada, I was supposed to be here for a year. So I'm like, well, how do I tell a patient they're supposed to come back in 3 years if I won't be here?
Yeah.
So I had to start talking to the team. Okay, who would call a patient and tell them it's time to come back? How do I tell you what if you aren't here in 3 years? How do we make it so that it's not person dependent and it becomes a system level change? And started to implement that so that it's not me in my work list annoying myself with, ring Sally because her pap smears due. It's like, that's not physician work.
So a little bit of health literacy and, kind of taking ownership of the care on the patient side, or having, these external supports to actually do these reminders. Like for anyone not in Alberta, we have these kind of guidelines and practice frameworks in place, provincially implemented programs just to like create these return cycles and get those adequately done. But then some of the EMR vendors are addressing and starting to build those into the workflow. But again, it's not done on a more coordinated level. It's more of just like, here is best practice guidelines, and then it's still up to the individual team to figure out how to manage these.
Yeah.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, chiropractors, dentists, and all other allied healthcare professionals can sign up for free and start checking out job opportunities from thousands of employers across Canada. We make it easy to advance your career with industry-specific job filters to help find your dream job or line up your next locum. You can also post jobs for free. That's right, if you're a clinic owner, manager, or a recruiting professional, you can recruit doctors and other healthcare providers for $0. There's no catch. Hundreds of new health jobs posted every week. www.cherry.health to get started today.
And it was no good when Sally's in front of me telling me she had a pap smear due a year ago. That's opportunistic, and that's not what we wanted to create. We wanted to create the 2.5 years later, she gets a call saying, hey, it's time to book you in. When can we book you in? That safety net was important to us as physicians, and we were able to create it, but we had to do some kind of creative things with the EMR as it existed in order to make that happen, and then to onboard the staff so that they could carry it out for us. Because if we don't trust it, we won't use it as physicians and clinicians.
Exactly.
Yeah.
Which EMR are you using, can I ask?
So we're using HealthQuest and MicroQuest, and they have been excellent with regards to talking to programmers, listening to the things that we want done about the program, adapting it for us. I think I'm their biggest, I'll email Janet almost on the weekly. Hey, Janet, blah, blah, blah. Be like, oh, that's a good idea. We'll get busy with it. Yeah.
How many of the different EMRs have you tried?
That's a great question. So in Australia, we were using Medical Director and Best Practice, which were developed by a physician for physicians. So it was really quite a nice, robust, and quite easy, user-friendly platform. Then I came to Canada. They were already on HealthQuest here. And then the Connect Care is coming, so I'm in there. So they're the four that I have been kind of part of, as in used on a daily basis. I think there were some other ones I might have
you
used
heard it
temporarily.
Dr. Smith, the charting coach herself, HealthQuest is the EMR of choice. What are your thoughts on Netcare? Like just in general, is this the miracle, or not Netcare, Connect Care? Is this the miracle solution to start reducing burden? I mean, I have not had the pleasantry of experiencing it firsthand myself. I just see all the commentary happening through Facebook. What do you think?
Okay, so we'll talk quickly about Netcare. So In Australia, there was no Netcare. So Netcare, for those of you who are not in Alberta, is the one-stop shop if you're looking for any diagnostic imaging pathology results, anything like that, and consultations, visits to hospital for the last 10 plus years for all of our patients in Alberta. Anyone with the Alberta healthcare card, you can go into this portal and you'll have access to this patient's entirety. It's amazing. When I was in Australia, we would have to say to the patient, did you go to the pathology department with the red or the blue door? And because, there were two different pathology service providers, and I'd have to call them and say, can you send the last lab report for? Oh, it would take up so much time. So now
If you
this
had a
one-stop shop is
colorblind
like a
patient,
miracle.
they'd be sending you on a goose chase to the wrong lab.
Yeah. Even finding out what medications they had last filled, you couldn't find in a central database as I was leaving Australia. I believe that is now exceptionally better, but still not as good as Netcare, which can find the scripts as well. Connect Care is the hospital-based electronic medical record, and it is the same essentially as Epic for those of you who are in like the US, or it's called something different in Ontario because they do have it in some of their hospitals there as well, I believe. And so Connect Care or Epic is a very big program designed to hold a lot of information and to have everybody being able to document in real time. So your nurses, your allied health, your physicians. So it contains a lot of data, and it is not intuitive. So you're having physicians doing 8 to 25 hours of training to figure out how to run this thing. So that's problematic.
That sounds like a lot. I mean, in terms of any other tool that we as physicians use, the suturing equipment, if you're literally anything, right? So why not spend some time learning how to use your charting tool?
Yeah,
maybe 24 hours is excessive.
So I agree. Doing some EMR optimization, having your EMR super user help you kind of design your templates or your lab requisitions or kind of make your use of the EMR easier is obviously important because it's part of the time saving. I think the problem with Connect Care is, one, it's siloed from your work if you're in family doctor world. So you've now got to log into this completely different portal to make sure you haven't missed any information about your patients. So that's a bit problematic about it. And it's now duplicating a lot of the work. So you've got the stuff, you can find it in Netcare, or you can find it in Connect Care, or you can find it in your EMR. So there's just that little bit of busyness about it. In terms of actual flow of work, you are now doing a lot more administrative work as a physician in Connect Care because you're putting in all your own orders. So it's about a 3-month slowdown before you feel like you're back up to productivity.
And then at that point, is it a net positive? Like, is this a step in the right direction and growing positive pains?
Yeah. The net positive when you're actually within the hospital system looking after the hospital-based patients. But when you're in community, in your own EMR with Connect Care existing outside of it, it's still that problematic problem. Yeah.
Do you think they'll be able to get it to the point where it works well in the community in an outpatient setting and also ties in with the inpatient system?
They're not going to let community family doctors use it as their EMR. This is the hospital EMR. So it's not available for family doctors unless they're in an Alberta healthcare clinic. So it's not intended to replace the EMRs that exist right now.
Gotcha. Yeah. Okay. So just hospital only. Now, have you been on the SCM system that Calgary had up until recently?
No.
It was cool. It was like a digital charting system in the hospital. Like when I did my training in Edmonton up until 2013, 2013 to 2017, all the hospitals were paper record based. And then coming to Calgary where they had this digital SCM system, I was like, oh, wow, this is fantastic. And so I'm just picturing like that next leap in evolution of that actual electronic health record being that much better. But the only things I see on social media are people not super happy with it.
Yeah. I think the good thing about us all on the same Connect Care system is I can now that I have access to it, see my patients who are in the hospital in Edmonton and what's happening for them in real time. So it is that ability to, no matter where your patient is located in Alberta in a hospital, you can kind of see what's happening for them and how the maybe referrals are progressing in the lineup and that sort of thing. So this has got some advantages, even though we all, like to whine and complain about new things.
It's therapeutic.
Yeah, exactly.
Get it out of there.
Validation.
Backing up then to, sorry, just in terms of backing up to like the workflow, what does your team look like? Do you have an MOA? Do you have an LPN? Do you have an RN? What does the clinic staff, the org structure look like where you're working?
Yeah. So in our particular environment, we have 15 physicians, family physicians in our small rural town. We're all in the one medical center in our small rural town. So we have a couple of people each day on the phone lines to take phone messages and book people in. We have somebody doing the MRI and ultrasound booking and following up to make sure that those are being booked and happening. We have somebody scanning in the e-faxes as they come in need to be assigned to different charts. So that's somebody's role each day. We have LPN nurse or two, depending. One is paid for by the primary care network, 50%. The other one's paid by us. And they do things like height, weight, blood pressure, baby checks, urine dips, and sending off cultures for us, ordering supplies for the clinic. We have a referrals dedicated person. So all I have to do is write cardiologist and do the letter, and somebody else knows better than me, which I think is important for your team, who's accepting new patients, who's the fastest one to get into, what do they need to have put in place before they will accept this referral. So we have that person. We have a third party person who negotiates with all the insurance companies and WCB and all of that for us. A clinic manager. And then we have the ushers who will put patients in rooms, make sure the drawers are stocked according to the photograph of how we like the drawers stocked, or the list of what should be in each drawer, clean the rooms and put the next patient in. So that's excellent. So we have we'll have 2 working consultation rooms for the day and our office where we do phone calls and messages. If I'm emptying my inbox, I will ask the reception to let them know the results, or I'll email through the portal, or I'll just simply tick it off. And then if I'm setting up like if I read an MRI report that says repeat me in 12 months, I will write that referral right now and put it into our referral portal, where it will be done and sent in about 9 months later, ready for the next MRI. So the next time I know that referral's ready is when I'm seeing the report.
And so it sounds like a big team. Did you say there was 15 physicians working there?
Yeah, and about 15 to 18 staff, because not all the staff are full-time. So about 15 equivalent staff and 15 physicians. So it's about 1 staff member for each physician.
How much of that economies of scale model do you think plays into having that efficiency, to the point where you have enough doctors that you can have a single person doing each one of those tasks?
Great question. So we know that physicians in primary family physicians, you're about 40-ish% of your salary will go towards clinic costs, whether that be, buying supplies, paying for the lights to be on, paying the rent, paying the staff. So we know about 40% of your wage is gone. That's if you're managing it well as a business. And so we're looking at how do you manage your business so that your team is optimized, so that we're getting the best value out of them and we're not wasting dollars because it's coming out of your pocket. If you've got a really slick clinic, you might get down to 25% of your wage. But that would be a very unusual situation. 30% is probably 30 to 40% is about normal.
Yeah. No, I'd say 30 is probably most of what I've seen and worked at. And then that gets you a pretty good amount of, back end support, but it definitely doesn't sound like as thorough and comprehensive as the team you've assembled.
Mm-hmm. Yeah.
Now, you make a good point there. It's not just about optimizing your own time and your charting and all these things, but then there's the, half of your costs, almost 40%, are going
Mhm.
towards paying other people and
Mhm.
enabling them.
Mhm.
How do you structure that leadership and within a medical clinic? Who is actually in charge of making decisions, or what seems to work best? Is there a clear single leader? Is there more of a like democracy going on? And then how does that flow down to all the other staff?
Great question. So I've worked in multiple different types of clinics. And so depending on the clinic style that you're working in will depend how you've set up your structure. So where I've worked previously, the owners have been the decision maker. We are owner organization. So we have, I think, 12 of us are owners and the rest are contracted physicians to the ownership. So for us, we put together a 5-person board, which will make most of the decisions, and we meet about once a month for that. I recently stopped being a board member, but we have a 5-member team and they each have a different role. So one is HR. So when you've got, Sally's late for the 3rd time this month, should we start sending letters? That goes to just one of the physicians, not to like random physicians. So that question will go from the manager to the physician who's in charge of HR. We've got one in charge of finance, one in charge of the team building, so that access improvement team. And then we've got policy procedure person, and then recruitment, like bringing in new doctors if we need to fill spots is an important part of that kind of ongoing sustainability. So the team, how do we empower the team? So we have a physician lead who meets with the heads of the team. So the nursing head, the reception head, the practice manager, and a physician meet together about, again, once every month to 3 months, talking about flow through the clinic, roles and responsibilities. What are we working on to improve efficiency? What are we bottlenecking, and how do we start to move that into different roles? What is being dropped in terms of, recall systems? And we just keep our hand on the ball that way.
I guess I'm just making it a regular practice to actually have
Mhm.
these discussions is probably where it all starts off, right? Because if there's no problem recognition, there's not going to be any solutioning or improvement.
Yeah. And it's not perfect, of course, but it's part of checking if your staff is allocated right. We did a number of years ago give everybody a clipboard and say, okay, every 10 minutes the buzzer goes off and you write down, what did you do in the last 10 minutes? And what that did was identify for us, oh, our nurse is doing MRIs and ultrasound bookings. That's not nurse work, and it's bottlenecking her from getting to the physical exam pieces we need to be able to get the patients in the rooms for the physicals. Let's take that off her plate, and that'll give her all this extra time to do the other pieces that are in her wheelhouse. And that was important.
Yeah, just like the physicians don't want to be spending time doing things that, is sort of within somebody else's scope. The same thing
Mm-hmm.
applies for the entire rest of your staff and how
Yeah.
you delegate that whole chain of commands.
Yes.
Well, and then in terms of just like having discussions and bringing these things up and like problem identification, that obviously necessitates having an open line of communication and an environment where people feel comfortable bringing up these topics or airing their grievances, obviously
Mm-hmm.
in a respectable way. How do you go about fostering that type of environment in a clinical setting?
Yeah. So typically staff know who their go-to person is. So it could be their direct person that they supervisor, or it could be the practice manager. We try and discourage a lot of staff going directly to physicians because that's more of that interruption of the day that we're trying to avoid. But if that is happening, sometimes it is to us identifying, oh, maybe there's an issue with going to that person or that person about the problems. And then that requires a conversation. So that's where that board member team could be helpful to say, okay, why are we getting these sorts of comments, and how do we manage that, and when do we need to bring staff together to have meetings and upskilling events as well.
The time and the place for these different things, because like you
Mm-hmm.
mentioned, that switching cost, if you're trying to do something and then something else pings you, even digitally, right now that the
Mm-hmm.
EMRs are getting more
Mm-hmm.
connected with the direct messaging systems in there, it's
Yes.
very distracting. It's an easy way to lose that efficiency in your train of thought.
Absolutely. So you're just looking at a computer screen, but you're doing high level work when you're looking at that inbox. You're taking that patient data and you're trying to remember their clinical presentation. You're trying to make ideas now on your working diagnosis and plan, and then how to communicate that to your patient. So you're looking at a computer screen, but you're doing high level work. No one else realizes that, right? So as your staff member comes up to you, well, you're looking at a computer just like they do. So they have no idea the level of concentration that you're trying to coordinate in your head. So letting that be understood, hey, I'll come find you, or please come find me at, and giving them some guidelines is really helpful for batching those interruptions.
Are there any other like leadership faux pas that you've seen in the clinical environments? What are those some commonly stepped on landmines that we should be looking out for in terms of how we manage staff, how we lead the team, how we structure the organization?
I think the rules from above doesn't go very well in any situation. So team leadership is something that is worth learning. So being the physician as a team leader, there are a lot of skills to learn here, and there's ways you can learn those skills. But having a commonality of problem that you're trying to solve together as a team, knowing that your team all brings something unique to the equation, and they know why something is or isn't working, or could have ideas on what isn't working. So encouraging your team to say, hey, the printer isn't working again for the third time this week, but rather than just whining about it. And what I did was I, called so-and-so and they said this, this, and this would help in solving this problem, is much better than whine, 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 whine. Or now you're going to be, calling all these patients and I want them done before tomorrow. And they're like, but, so that from the top down kind of leadership does not allow your staff to have that level of responsibility, the job satisfaction. We need to help them understand how they can be successful. What does success look like? So that they can win too in their day and be part of a functioning team and important for our patients and doing important work, not just grunt work.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, dentists, chiropractors, and all other allied healthcare professionals can sign up for free and start checking out job opportunities from thousands of employers across Canada. We make it easy to advance your career with industry-specific job filters to help find your dream job or line up your next locum. You can also post jobs for free. That's right, if you're a clinic owner, manager, or a recruiting professional, you can recruit physicians and other healthcare providers for free. There's no catch, $0, hundreds of new health jobs posted every week. www.cherry.health to get started today. No, exactly. Yeah. And really making it, like collegial, us versus the problem, as opposed to me versus you or him versus her.
Me giving you jobs.
Yeah,
You'll hear a lot of, but I'm so busy, complaints. They'll come in and say, I asked my MA to do this and she said she couldn't. She was too busy. I'm like, yeah, probably the way we asked. We told rather
one
than
thing
asked.
Oh, sorry, go ahead.
No, it's all right. We just, if you just tell them they're doing it, then you're going to get resistance versus a conversation. Yeah.
Nobody likes that. Yeah. The art of leading people.
Yes, correct.
One of the things I've noticed is the clinics that seem to have the staff retention thing figured out seem to be the most effective. You get there and there's an MOA who's been there for 10 years. There's a nurse who's been there for a long time. What leads into that, or what causes the opposite, rapid turnover?
Yeah. So staff turnover can be related to satisfaction, and that can be related to leadership and your sense of responsibility and the way you can be successful in your role. So nobody likes an environment where you don't feel like you're successful, or that you're constantly being micromanaged and you have very little responsibility or autonomy. So that certainly for both the physician, clinician, and the staff is important. So that's one of the factors. The amount you can pay someone as a family physician in a family physician office, we've lost people to Alberta Health Services simply because the wage and conditions is better. Like the wage and the benefits and the pension plans are just simply something we cannot afford to provide. We take that into account and know that income is important for people to retain their position. So we really worked hard to say, how can we, or can we kind of do our best to make sure wages are at the best we can offer them, but we still can't compete with organizations. So that makes it tricky. If you've got a good person, they'll be headhunted by other bigger organizations.
So multifactorial, obviously, like the pay and the environment, just the relationship dynamics, the respect,
Yes.
all goes into it.
Respect,
Yeah.
autonomy, being having that level of responsibility, and being valued for the job you do and for what you do bring to the organization. Yeah.
Now, you mentioned we're losing physicians to working elsewhere, including within the hospitals. What is the problem with the primary care model as it exists right now? Is it a billing code issue? Is it the structure of the system in general? There's probably no easy answer for this, but what kind of changes would you like to see worked on to make that more of a equitable decision for physicians, where they're not it's an obvious yes one way or the other?
This is a great question. I think I was more meaning our staff want to move to the hospital because they get better paying conditions for the work they're doing. So don't tell them. No, not really. They know that. So why are physicians moving into the hospital space? Well, it is similar to that. So when you're working within the hospital environment, you're not paying overhead. So you're not having to do the wage, the rent, the lights on, the hire and fire of staff, the paying the staff wages. That's all taken care of by the big organization. So of course, if you're in family practice, you have to see a certain number of people in order to, patients coming through the doors, in order to pay for the rent, then the lights on, then the staff being here, all your insurance and other professional expenses for the year. That is, so the first so many patients for the day or the week are paying that. And then you're paying taxes, and then you get to keep the rest. I think that's one of the hard bits. And then the second part of family medicine is if you get into that mental mindset that you're not being valued or that you are being dumped on by specialties or that you're not important, why would you stay, right? If you're feeling like that within your day, you're not having that joy of medicine. And so certainly, I absolutely understand the whole dreading work, feeling like you're, stop asking me to do things. I don't have room for anything more. Don't you understand what I'm already doing already? That was the first 15 years of my family physician career, was that overwhelm. But that clinical experience, your experience of medicine, can be very different when you learn some of that mindset tools of, hey, I want to be here. I choose to be here. I'm enjoying this part of my day, not just focusing on the things that aren't going well about my day, which was very much my experience before.
Yeah, when you're already feeling underwater, and then that sense of underappreciation is just you pushing your head down further, that really weighs on a person.
Yeah, that's right. So we love family medicine because of the variety. It's amazingly fun. We love the continuity. We know we do amazing care when we're doing, as a family physician. We're highly evidence-based in regards to reducing morbidity and mortality for patients. We get to do a wide range of medicine for our patients. And just specialists in their clinical day as well, who have their private rooms. We're paying overhead, we're paying staff. That's a whole layer. The whole business layer wasn't necessarily taught as we were doing medicine, and something you kind of got to put together at the end. So Charting Champions I like because it's kind of like finishing school for doctors. You get all the other little pieces that you may not have picked up along the way in medical school. Yeah.
Well, absolutely. I mean, we had like a 1 hour session times 2 or 3 on business administration, I think, during the entire 6 years of training in medical school. So it's like vastly undertaught. And I don't know, there's kind of this like, you're here to do the healthcare attitude, but I mean, you need to get your business knowledge under you too, right? You come out, you graduate, you do your training, and you're like, okay, I've spent thousands upon thousands of hours like learning, diagnosis and the pattern recognition and treatment algorithms, and then it comes to like, and now what? Like, I got to actually run a practice, and it's just very overwhelming. Well, okay, so I've learned a lot today. In terms of how can people get a hold of you, what would the best way to get there be like?
Yeah, so it's just chartingcoach.ca is the website that has all of the different programs attached to it. And then you can find me on my own podcast, Sustainable Clinical Medicine podcast, where we have interviews with physicians and clinicians who have kind of redesigned their day to create sustainable models for themselves. So my hidden agenda is to get you all home so you can have a life outside of medicine. So that's what I just love about what I do, is I get to help physicians create hours of their life back. So super fun.
What would people expect if they're signing up? What do the programs actually entail in terms of time commitment, in terms of the medium that they would interact with you through?
Yeah. So it's all very much what you're needing. So we get the, as you kind of join the Charting Champions program, if it sounds like something that you're interested in, you get the foundational modules of how do we do these steps, and it takes an hour and a half in total. So we wanted to keep this short, snappy, and very easy to start to implement. And then each month we have, and there's no obligation to come to any of it live, we do 6 coaching calls where you can come on and get that specific one-on-one help, because you'll have physicians coming in from the hospital system, urgent care, family medicine, neurologists, oncologists, like all the different types of physicians. So we want to be able to make it perfect for them with that access to their executive coaching peers who can help them with that specific help. We have that online peer community where they can get support, encouragement, have a wine, have a bad day, and get the help they need there. And we bring a guest coach in every month for an additional 3 hours worth of training in a different topic. And then all of the call replays are inside the membership, and they get main pro points or college points for each hour they're in the program they can claim. So we love it because it's comprehensive and it's lifetime access. So they get to come in, pivot, do different seasons of their clinical day. Yeah. So pretty fun.
No, that's fantastic. I will say I've seen you talk at a conference before, and after doing your session, you were taking some Q&A, and there was some like fantastic examples of questions coming out of just dysfunction, and how you like very quickly were able to like establish that common ground and then solution problems, like even right there on the spot in front of a room of people. So I have no doubt that you'll add a ton of value for all the people listening to it. So thank you so much for chatting with me today. I really appreciate it.
Yeah, I loved being here. Thanks so much, Jordan.
Have a good one. Take care, everyone. Bye-bye.